Hello everybody. Today's Pearl of Wisdom is going to be about the palmar space infections of the hand, with the main take-home message being to recognize them, decompress them, and save the hand. To understand this topic better, it makes sense to start with the anatomy of this area. When we talk about the palmar spaces, we are referring to deep potential compartments in the hand which are formed by fibrous fascial layers. For the purposes of easy understanding, they are generally divided into the mid-palmar space, the thenar space, and the hypothenar space, which is not shown on this diagram. These spaces are deeper to the superficial spaces such as the radial and ulnar bursae. Looking at this diagram on the right, which gives us a better three-dimensional understanding, we can understand how the floor of these spaces is formed by the metacarpal bones and the fascia over the interossei. The contents of the space, strictly speaking, are only the lumbrical muscles, and just superficial to the space are the tendons and the sheaths of the flexor tendons. That's the flexor digitorum superficialis and the flexor digitorum profundus. However, often you will find these tendons being included in the contents of the space. It's a strictly academic discussion, doesn't matter too much. The most important thing to understand is that these spaces are generally potential spaces, meaning that they can fill, but usually they are not filled with anything other than these contents. Looking at the thenar space, your floor is your adductor pollicis, and looking at the hypothenar space, your floor is the fifth metacarpal bone. You can see in this diagram that the thenar space and the mid-palmar space are separated by a very thick septa called the mid-palmar or oblique septum, and the mid-palmar space is separated from the hypothenar space by the hypothenar septum. Generally, these septa do not allow infections to immediately cross from one space to the other. However, infection can track from these spaces into the lumbrical canals and into the web spaces of the hand. This diagram hopefully reinforces what I explained in the previous slide. Just to summarize, if you imagine that where my laser pointed now is dorsal and at the top is palmar, you have on the radial side the thenar space, which basically is just deep to the tendons of the flexor digitorum profundus and superficialis with the index finger. The content is the first lumbrical. I would say this space is again deep to the radial bursa. Immediately dorsal to this space is the adductor pollicis, which we saw in the previous diagram, and below that would be the first and second metacarpals along with the fascia over the interossei. Separating this from the mid-palmar space is the middle palmar septum. Then you have your mid-palmar space, which is actually a bit bigger than what this diagram would suggest. But this space is just deep, or including the tendons of the flexor digitorum profundus and superficialis for the third, fourth, and fifth fingers. The contents are the second to fourth lumbricals. It's again deep to the ulnar bursa, but some people would include the ulnar bursa as a content. The floor are the third, fourth, and fifth metacarpals, along with the interossei fascia. The medial palmar septum separates this space from the hypothenar space, which you can see is a very small space on the medial aspect of the hand, with the floor as the fifth metacarpal. And this space is just lateral to the hypothenar muscles. So, talking about the infections, the most common infection is that of the thenar space, and we've talked about its boundaries. The next most common infection is the mid-palmar space, which is the middle space and the biggest one, and the rarest infection amongst these is that of the hypothena space. There is another entity which is included in the deep space infections of the hand called a collar button abscess. In the previous slide, you could see that these spaces are continuous with the lumbrical canals, and therefore an infection in these spaces can track into the canals, and an infection in the web spaces can track through the canals into these spaces. And this is often known as a collar button abscess, and most commonly can track into the mid-palmar space. Coming to the sources and organisms for these infections. Classically, the classical mechanism of entry of these organisms is through penetrating trauma. Other than this, a flexor tendon sheath infection can track proximally, and it can lead to an infection of these spaces. You can see that the flexor tendons are just superficial, or the superficial content, the most palmar content of these spaces. So infections there can track into the spaces. Infections of the bursae, the radial and ulnar bursae, again these lie just superficial or volar to these spaces, and infections can move down. Skin and soft tissue infections in the palm of the hand, and iatrogenic sources such as an injection for a condition such as trigger finger. The most common organism is, as for most infections in soft tissues and in orthopedics, Staphylococcus aureus. Streptococcus is a close second. The empirical antibiotics which generally cover these are flucloxacillin and co-amoxiclav. We can broaden the antibiotics to a second or third generation cephalosporin if the patient is diabetic or immunocompromised. If the portal of entry was from a human bite, think of Eikenella. This is often uncovered only after prolonged cultures for 5 days and often requires different antibiotics according to the local policy. Animal bites, we think Pasteurella, and we always want to cover gram negatives and anaerobes if we think the mechanism would predispose to these organisms. Remember that the hand is an interconnected web, and a neglected trigger finger injection can become a deep space disaster. So even clinic procedures such as percutaneous trigger finger releases could lead to this disastrous condition. Coming to the clinical presentation of this condition, the patient can come with the primary symptom is usually severe pain and inability to move the fingers normally. Moreover, there can be a loss of palmar concavity, which is classically seen in a mid-palmar space infection. In a thenar space infection, often the thenar eminence is blown up and can look up like a blown up glove. Sometimes you can have pus even visible. In a hypothenar deep space infection, there'll be swelling over the hypothenar eminence. Based on the finger which is painful to move, and that is painful on passive or active flexion, we can also localize the infection. Painful flexion in the thumb suggests a thenar eminence infection, thenar deep space infection. For the middle ring and little finger suggests a mid-palmar space infection, and pain on passive or active flexion of the little finger suggests a hypothenar eminence. Investigations, this is usually a clinical diagnosis, but supporting investigations can be an X-ray to rule out foreign bodies and gas, an MRI to help us know the extent of the infection over deep collections, and routine blood tests such as full blood counts, CRP, and blood cultures to give us circumstantial evidence and also help in tracking the patient's recovery. An important question that often arises in our minds is, why don't these infections just spread into the forearm? What keeps them restricted to the hand and causes such massive swelling in the hand? Why can't they just spread? Well, as we saw in the first couple of slides, the thick fascial septa sort of prevent spread of contents from one deep space to another. Proximally, the spaces are sealed off from the forearm by the carpal tunnel. However, the carpal tunnel offers a lot of resistance, but pus can escape via the carpal tunnel into the peroneal space. And this is a superficial space in the distal forearm which is continuous with the radial and ulnar bursa. So if the infection in the deep space spreads superficially into the bursae, from there it can then spread into the forearm through the space of perona, and this would be via the carpal tunnel. In a normal situation, the carpal tunnel offers significant resistance to allow against allowing the spread of this infection into the forearm. So why don't we just sit on these conditions, just throw some antibiotics at them and allow them to be reviewed later on by a more senior person? Well, the reason we don't do this is because infection of these spaces is considered a surgical emergency. These are very, very small spaces, and as I mentioned earlier, there's not really much room or routes for the pus to leave these spaces. So the pus forms under high pressure in these spaces, and this eventually ends up increasing the interstitial pressure of these spaces. Once the interstitial pressure increases more than the venous and arterial local pressures and capillary pressures, this causes ischemia, which can progress to necrosis and an entity called compartment syndrome of the hand. All in all, pus in a closed compartment is a vascular catastrophe, and that applies not just here but to any place in the body. On top of this, in the background, we can have deeper spread to the bones. The metacarpals and the fascia over the introitia form the floors of these spaces. You can have sepsis with significant systemic deterioration, and you can have necrosis of these intrinsic muscles of the hand, which in this case would start with the lumbricals, which are the content of these spaces, and this can cause a permanent claw hand deformity or an intrinsic minus deformity. So please, please, please do not sit on this overnight hoping that IV antibiotics will work. They usually don't. Often you need to inform your seniors immediately, elevate the hand, and potentially get theaters ready for a incision and drainage procedure. So what do we do in these situations? Well, the first thing we all know is source control. So the problem in this situation is the tissues, and they're walled off, and it's very difficult for antibiotics to reach these areas. So you need an urgent incision and drainage, and this needs to be done in theater to allow for a thorough job. You can use Brunner's or zigzag incisions, but you have to respect the flexion creases of the hand. You should decompress, wash out, and leave open, as you can see has been done in this picture on the right. You then simultaneously, and you should start the patient on IV antibiotics. So empirical cover for staph and strep, that's usually a Fluclox or IV cormoxicillin. Broaden it in the cases of diabetes, animal or human bites, or immunocompromised patients. And try to start tissue or pus for culture before starting these antibiotics, if at all you can, just to improve the sensitivity of the culture and sensitivity test. Next thing that we would do would be recovery. So you need to elevate the patient's hands, splint them in a safe position, which is usually the intrinsic plus position, and you need early hand therapy referral. You'd also need to be very vigilant and wait for recollection. You can sometimes secondarily close these, or sometimes they do need plastic surgical interventions to attain definitive coverage. To summarize, your job is to recognize, start the IV antibiotics, and call hand surgery or your senior early. The take-home messages are If you see a patient with a very swollen hand or hand pain and pain on passive finger flexion, think of a deep space infection and try to localize it based on how it looks and which finger is triggering the most pain. Please understand this is a surgical emergency. Pus in a closed compartment can lead to compartment syndrome of the hand. And the third and most important take home point is incision and drainage is the definitive management along with intravenous antibiotics, but you have to call hand surgery or your senior or the consultant on call as early as you can. Do not wait to present this patient in the morning thinking that it is a routine superficial infection, because it can lead to disastrous consequences. I hope that gives you all the brief summary and decent understanding of these infections. I've tried to keep it fairly general and not delve too deep into um, more details. I hope this was helpful for you all, and if you have any questions, please leave it in the comments below. Thank you.